Dr. Eric Ye, who's going to be presenting. For those of you who don't know Eric, Eric did a bachelor's of science in physics of all things. I don't know what possesses anybody to do a bachelor's in physics and go into medicine, especially sleep medicine. But he did that at the University of British Columbia in Vancouver, and he's got his medical degree from Peking University Health Science Center, which is part of Beijing University. Dr. Ye then came to University Hospitals and completed his family medicine residency here and a sleep medicine fellowship as well. And today he is going to be talking to us about referrals and the relationships between primary care providers and specialists in sleep medicine.
All right. Well, thank you, Sushil, for a intro. I was thinking it's like, okay, maybe I would need to do intro myself this time, but thank you very much. And then, so can you guys see my screen okay? And it is not a presenter view, right? Okay, it is a full screen. Okay, good. So the topic today is, well, more than a referral. I think 2-3 years ago, I had the similar presentation. It's called a synergistic approach. Obviously, coming from family medicine background, I really do believe that, I saw a lot of problems or potential gaps between primary care and the specialist care. So now I became a specialist. This is also a topic that's dear to my heart. Like, how can we as a group, as a specialist, better provide help? And then what are they looking for? What can we provide? And how can we make this better? Okay, so this is the topic that we're gonna go through today. So here, oh, there, very good. So just to go through some objectives here, a quick recap on sleep disorder epidemiology and its financial burdens. There's a famous paper in 2007, well, famous to my mind, that was a big primary care research that was done in North Carolina, particularly with sleep. And we want to understand our referral base. I have expanded the surveys that I did a couple of years ago to various different specialties. And then I think it's very interesting to look at the result. And then obviously today, the presentation definitely will welcome a lot more discussions, whether, in person here or with online. And how do we grow a helpful and positive relationship with our referring providers? Okay, I've got to watch the time. I've got quite a bit of slides here. So global prevalence and burden of OSA. This was an interesting article that I found that kind of really talk about OSA, in particular, the global prevalence. And it is estimated with 936 million people with mild and more sleep apnea and 425 million people, adult age 30 to 69, adult age 30 to 69, with moderate or more severe OSA. And so therefore, they're thinking about 1 million people affected. So with the prevalence exceeding 50% in some of the countries and effective diagnostics, treatment strategy are needed, blah, blah, blah. When I first saw this, and then and that's what I included in my screenshot here, it was funded by ResMed. I was like, so that they tried to tell us that there's more than, it really is. So I put it down in perspective. World population was 6.6 billion in 2019, and do a little math, that goes about 12% with the least mild OSA, 5.5% with moderate or more OSA. But granted that this is actually only the adults between age 30 to 69. So I think, give or take, this prevalence number could be a little bit higher than what we're used to. If you look at 12 and 5.5%, that's about right, what we are, what we know. But then this is only age 30 to 69. So anyway, it is an interesting thing to kind of have a global prevalence type of estimate. And then we won't go into the methodology of how they estimate it, but I just thought it's an interesting number. It's a 4%. Yeah, I believe. No, they used the 2012 ASM, which is the 3% and around. Yes, you're right. So, which are the countries that has the most number? Okay, and obviously most of the top countries here are there because they are large in terms of populations. So China, of course, is there. India is there. United States is there. However, I want to have a really quick trivia here because one of my dear friend who is a professor at Oberlin just recently went on Jeopardy and then was a one-day champion. So, you know, I got to look into this trivia stuff. And who is number 4 in terms of population size in the world? So number 1 was China, number 2 was India, number 3 was United States. Who is number 4?
Malaysia.
Rick, you're wrong. Keep guessing, pretty close.
Japan.
Not Japan. Japan is actually number 10.
Brazil.
Brazil is number 5. All right, everybody gave up already, right? The double jeopardy, no. Okay, so actually it's Indonesia. All right. And that's interesting because number 6 is Pakistan, number 7 is Nigeria, number 8 is Bangladesh, and number 9 is Russia. So anyway, the lowest one here is France, who is, I believe, number 22. And then this is to year 2019. Yeah, anyway, so stop that to bring in some interesting things here, okay? And so this was a study that as a national that was done at the with the veterans. So to look at the trend of sleep disorder from year 2000 to 2010. So they found that sleep apnea was 47% and insomnia was 26% was the most common diagnosis among patients with any sleep disorders. And there was a 6-fold relative increase in total sleep disorder prevalence over the study period. PTSDs, which triple over the same time period, was associated with the highest prevalence of sleep disorders among the comorbid conditions evaluated. I thought that was an interesting trend to look at. I tried to look into it. It kind of gave me some explanations as to why the trend is going up. But I think to me, the highest reason or the most probable reason is people's awareness about sleep disorders. So if you look at this trend, it's very interesting from year 2000 all the way to 2010. Obviously, you see everything, every single disorder basically just gradually go up, with the exception in my mind, hypersomnia. You see that the purple box did not really get that much bigger compared to the others. Okay, so sleep disorders are there. People are recognizing that the trend is going up, and then it's only expected that this trend will go even higher. Okay, so it is a global issue. So just real quick, we already did quite a bit last year when I was going through this. Sleep apnea costs a lot, or sleep disorders cost a lot. $150 billion in 2015. That was a study that was done, and a couple different studies that also show, a study done in 1988. It says that the cost related to sleepiness was about $50 billion. In 2000, annual cost to late shift was about $65.2 billion. Direct cost of insomnia was $14 billion. That was done in 1955. Yada 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 yada. So in 2020, the number has gone up to close to $100 billion. That's for insomnia. Okay. So going down to epidemiology, I kind of take a look at this compared to the study that was funded by ResMed. Basically, percentage-wise, it's about the same. We have a 3% increase in US populations in 2015 to now, from 320 million people to 332. So not a great increase in terms of population, but anyway, if you look at this, it's a lot of population that has OSA and still remain undiagnosed. Okay, so barriers to diagnosis and treatment, general public awareness, primary care physician education, which is actually the main thing I want to talk about in our presentation today. Diagnosis and treatment costs, employer and payer investment on chronic care management. But it's interesting if you look at that, while usually covered by payers for qualified patients, cost average $2,000 per year for testing, appointments, treatment devices, and surgery if necessary. That's on average. That's quite a bit of money, although if you come down to it, and that amount of money usually does not meet your yearly deductible yet. So if you think about that, that's a lot of times people's concern, right? So costs associated with OSA in the United States, annual per patient diagnosis and treatment costs are 67% less than leaving patients undiagnosed. If you look at the breakdown here, undiagnosed wise, cost per person is about $6,000. Whereas the diagnosed one we already covered is about $2,000 per patient. So big thing about their lost productivities, workplace accidents, stuff like that. Motor vehicle accidents, MVAs. Diagnosing and treating all of the Americans with OSA could save you $100 billion. That's an interesting way to look at if you were to treat everyone. And another thing is, if we were really to treat everyone, do we have the capacity to do that? And how do we do that? Obviously the CPAP companies are going to be very happy, but how do we get to that point? So this is a breakdown. You can see, I want to see if I can get my, healthcare costs, non-healthcare costs, and that between the diagnosed and undiagnosed. And in the future, hopefully this is all healthcare costs. Okay, so $62 billion is how much you will spend compared to that. So therefore you come down to saving $100 billion. All right, so that was enough for the epidemiology review, as well as the cost. Just to know that this is a big thing in the society that we live in right now. And it affects people's quality of life and other issues as well. But then we don't go out there and just put up a stand or, would be in the carnival and say, hey, this is sleep medicine, come by and, take a look. Usually they come through to us through some sort of referral base, right? So obviously primary care physicians is one, bariatric services, they are obviously doing that because of necessity. And then we have endocrinologists, cardiologists, pulmonologists, neurologists, ENTs, anesthesia, and sometimes self-referral. Okay, so these are our primary base, primary referral base. Then, like, what do they know? How are they managing these patients? And what are they expecting from us? That's a big thing that I want to cover today. Okay, diagnosis and treatments. So this is a survey to a lot of patients there. What types of doctors diagnose you with sleep apnea? So it's interesting how still 64% is diagnosed by sleep specialists, all right? And 21% is diagnosed by pulmonologists. So it's about 85%. And general practitioner or primary care internist, 10%, and the rest, the rest of the 10%, all right? Time between initial warning about sleep apnea risk and diagnosis following a sleep study. 14% of them is 0 month, 39% of them is 1 month, so about 53% of them has it under 1 month, which makes me kind of wonder, is that a similar result that we can provide here in the Cleveland area, both at the VA, UH, Metro, CCF, whatnot? I kind of think that we're more in the 2 month range, 17%. And then, but at least we're not 4 or more months, I don't think, in most cases. So I did a quick survey. Sorry, the things are small. The snapshots are small, but then I will read it out to you guys so you know what I asked them. And this time around, not just in primary care, I've also advanced the invite to cardiology and our dear pulmonology colleagues. And then the pulmonology colleagues have graciously responded with, gave me 23, filled out 23 surveys. I did, as a disclaimer, when I tried to forward this, I did try to ask them to exclude sleep people, but somehow it was blasted to everybody. So I believe one of sleep medicine docs told me that she filled it out. Oh, did I just mention she? But anyway, there's a lot of she's here. Mentioned out by accident. But anyway, just take that in mind. Okay, so and then out of the family medicine people, 29, it's actually broken down between two separate groups. One is a community group who they happen to invite me to give them a very talk, and then I just thought that what better time to ask them to do the survey at the same time. And then also our the main campus group as well. Cardiology, unfortunately, had only 2 responses, so I did not include the answers here. And endocrinologists, I didn't get any response. Anyway, so real quick.
Neurology is okay.
That's right, that's right. And then we need to perfect these quick surveys too. Okay, so first question, how often do you encounter fatigue as one of the chief complaints? 25%, 25 to 50, and so on. And I added this question this time, is sleepiness and fatigue the same chief complaint to you? I just kind of want to see what people's response to that is. When the patient chief complains fatigue, do you usually ask them about their sleep quality? And what percentage of your patient do you suspect of OSA, regardless if they complain about sleepy or being tired? Of your patients that have OSA, what percentage of them are under treatment? How comfortable are you with the following type of management? Prescribing in-lab sleep study, home sleep study, prescribing PAP versus managing PAP. Do you regularly check on their PAP usage and compliance? If your answer is yes to yes, I regularly check on their compliance. How do you do it? Rely on what the patient tells me, or actually check their machine download, or AirView and stuff like that. Do you have a sleep specialist available to you if you need to refer a patient? And the next one is, are they accessible for questions? Okay, we always say we are, but are we really accessible to them in their, okay. Or do they even know that we're accessible? Okay, do your patients complain about difficulties with regard to getting a sleep study or a sleep medicine appointment? I thought those were interesting questions, and I got some interesting responses too. Which part of the sleep study report do you read? Recommendations, diagnosis, summary, detailed reports, graphs, or I have never ordered a sleep study? What are the top 3 sleep diagnoses? This is one is family medicine or primary care specific. What are the top 3 sleep diagnoses you encounter in your practice? OSA, insomnia, and then the 6 domains of sleep disorder. Which of the following conditions are you comfortable managing on your own? All right. And these 2 are more cardiology and pulmonary specific. In your specialties, what will make you automatically think about your patient's sleep quality or even routinely order a sleep study for them? For cardiologies, I was thinking, CADs, CHFs, AFibs, other arrhythmias. And in pulmonology, I put down COPD, pulmonary hypertension, asthma, and then of course, leaving other for their other inputs. So now let's look at the results. I think it's very, very interesting. So we'll start with our dear pulmonology colleagues. What is your current position? So more than half of them were attendings, about 1/3 of them were fellows, and then maybe 2 APPs that actually filled this out. So how often do you encounter fatigue as one of the chief complaints? So more than 50% of them saying that less than 1/4 of the time, but the other 50% is, more than 25% of the time they do encounter patient tell them about fatigue. So I think that complaint is still very high. Does sleepiness and fatigue mean the same thing to you? I think everyone but 1 or 2 that says yes, they mean the same thing to me. So I'm still pretty glad with this answer. When the patient complains of fatigue, do you usually ask them about their sleep? I'm glad that nobody said never, but probably just, but not always. They don't always ask about their sleep. About 50% of them always ask. The other 50% is sometimes. So in your specialty, which conditions will make you automatically think about patients' sleep quality? So pulmonary hypertension actually is number 1. So it's 15 out of 22, about 70% of them will think about it automatically. But I think there's one person who put it out, these other things. So she's thinking about sleep a lot, heart failure, hypotension, hypoventilation, etc. So what percentage of patients do you suspect of OSA, regardless if they have complaint or trouble sleeping? So about 15% of them says less than 1/4 of their patients, but most of the providers still suspect that most of their patients, a lot of their patients have, some sort of sleep breathing disorder. Of the patients that have diagnosed of OSA, what percentage of them are under treatment? I am pretty surprised but not surprised with this result that about 70% of them reported that less than 50% of the patients are actually under treatment for the OSA in the pulmonology, umbrella, So anyway, how comfortable are you with the following type of management? Usually they're pretty comfortable prescribing in-lab sleep studies, prescribing home sleep studies, quite honestly, less comfortable, and which is a similar result to 3 years ago. People think that, maybe prescribing in lab, they just like, boom, boom, boom. But who is suitable for home sleep apnea tests? They're not so sure, it seems like to me. Prescribing PAP therapies and obviously managing PAP, people are getting more and more less and less comfortable. So this is the interesting part. 50% of them check on their PAP usage, 50% of them don't. So how do they check? About half of them, the ones who check, or more than half, check their machine download, and 20% of them rely on what the patient tells them. Do you have sleep specialists available to you? Are they accessible to questions? About 65% of them think that we are accessible, another 30% not sure, and then a very small fraction of them saying no. Okay, last part in the pulmonary. Do your patients complain about difficulty with regards to getting a sleep study? Most of them say yes. So that's something interesting feedback there. So sleep studies, they still read the recommendations, as most of them read the diagnosis, understand it. Very few of them would actually go down to the last page, where we spend a lot of time to put our hypnogram up. They don't really look at it. Okay, so which of the following conditions are you comfortable managing on your own? This is the part. 83% of them responded that they're comfortable managing OSA patients on their own. But only 50% of them regularly check on their PAP usage. I don't know. I mean, there may be a discrepancy between the two questions, but
I find that higher than I would expect.
50% they actually checked. Yeah. But that's also interesting because when it comes to comfortable managing OSAs on your own, but that does not really correlate to how often they really check. So, but maybe they don't think that they need to check, to manage OSA. But this is by no means saying who is better, who is not. It's just like a feedback from people. So just real quick to go through the next couple of slides. From primary care in the community side, granted that this survey was done with many of them actually are first year or transitional year residents. Okay, so how often do you encounter? You can see that many of them still encounter fatigue that we know. And they do ask about sleep. Some people never. And percentage of patients suspect OSA is a bit lower than how a pulmonologist would be suspecting their patient population. Of your patients have diagnosed of OSA, actually still more than half of them are not under treatment, to their knowledge. So they are not very comfortable in terms of prescribing or asking for a sleep study, but many of them are actually more comfortable getting a home sleep study versus a in-lab sleep study. Very uncomfortable prescribing PAP versus uncomfortable managing PAP. So checking and all that, but most of them, basically nobody probably knows how to check the machine downloads at all. Do you have sleep specialists available to you? Yes, no. So which of the following conditions are you comfortable managing on your own? Most of them, I mean, the highest, I was surprised that they're more comfortable managing insomnia and restless leg than they are comfortable managing OSA in a community setting. I thought that was very interesting. So coming back to our main campus group, this is a survey with 9 responses. Quite a few of them are attendings and residents, and then APPs too here. And the fatigue and chief complaints and all that, it's actually not that different from the rest of the group. So I'm glad that, at the CMC here, that most people still ask about their sleep quality. Percentage of patients that has OSA, actually, they don't think that their patients have that much OSA, that high prevalence of OSA if they didn't have any complaints. Of your patients that have the diagnosis of OSA, again, less than 50% of them are on, less than 50% of the providers who filled out this survey think that less than 50% are on treatment. Okay, again, very uncomfortable managing CPAPs and prescribing CPAPs even. But in the primary care group, you can see the difference that they're more comfortable prescribing at home sleep apnea tests in some sense, than prescribing in lab. So do you regularly check on your PAP usage? I'm very surprised that 2/3 of them say yes. And then they do not check on the machine downloads. They rely on what the patients are telling them. Do you have sleep specialists? And then 2/3 of them think that maybe they're accessible for questions. Do your patients complain about difficulties regarding getting into a sleep study? Quite interestingly, probably about less than half, yes, less than half, about half says no. They read the summaries, recommendations. Here, top 3 sleep diagnosis: OSA, insomnia, and circadian rhythm. I don't know what I say about that, but probably restless legs should be higher, but these are still the top 2, and we know that, right? Which of the following conditions are you comfortable managing on your own? There's 5 respondents that says that they're comfortable managing on their own with OSA, insomnia, and restless sleep. We'll talk about primary care managing insomnia, for example, in another article that I read later. So this is just to give you a sense that people saying that they have ability or comfortable managing these things on their own compared to what they're actually doing. We're not sure if they do have the adequate amount of education or resources to really enable them to manage these things on their own. And if not, how do we help them to get there? I think that's the major part of discussion that I want to address today. Okay. Sounds like I have a lot of points I want to address today. So anyway, understand your referral base. What are they looking for when making these referrals? So timely and reliable ways to improve patient care, uncomplicated reports, sleep study reports that's easy to follow. And I think adequate support and education is what they're looking for. All right. A big thing that they're looking for. Fast appointment times for testing appointments and follow-up communications. And I think we can mix and match, combine the 0.3 and 0.5 together. Support to me is communication. So real quick, back a review of this paper that we look at before 2007 North Carolina paper. Basically, this is to indicate, this is a big research on 5 different sites in North Carolina, primary care sites. They have 4 sets of questionnaires for people to fill out to really try to get a glimpse to understand the prevalence of sleep disorders among primary care patients. So the key points from this paper that big thing here, participant reported fair and poor health, and with history of pain syndrome has significantly higher rates of all 6 sleep disturbances items. Sleep complaints are highly prevalent in primary care patients, about, depends on how you look at it, different sites, 13 to 55%. Mental disorders were significantly associated with sleep complaints. All right, so just real quick here, you can see that just kind of read out these questions real quick. Feeling sleepy greater than once a week doing daily activities, more than half of them, all right? And then doze off more than once a week doing daily activities. This is surprising at 37% people just doze off. And at nights, legs feel unpleasant, tingling, creeping, restless more than once a week, about 28% of them. And then, oops. Okay, and snoring loudly more than once a week, 33%. Reports stopping breathing or gasping, 13% of them. Wakes more than 3 times, 34% of them. Those were big numbers, all right? So these are questionnaires that they put out. I'll just put in an example out here. So, oops. I want to talk about this, is the current problems among our patients and how do we better address that, right? So high prevalence of sleep disorder, we know that. Lack of mentorship and the availability of specialists and communication with the specialists. Lack of mentorship, I think, is something where we might be able to look at even more, like the outreach program from specialties itself, right? So this is a paper that was done in, I believe, 21, sorry, that was just published in Journal of Clinical Sleep Medicine. Primary care provider evaluation management of insomnia. I highlighted down there in the conclusion part. If you can read it as too small, I'll read it out to you. Medications are often prescribed as the first-line treatment for insomnia. Cognitive behavioral therapy for insomnia, known as CBTI, remains underutilized despite robust evidence suggesting that CBTI is a safe and effective treatment for insomnia. So I don't know, like people in the survey, sorry, go ahead.
So who has to ask for this? In my experience, it can't be the SNPs.
Right,
It has to be the primary care physician. Have this,
right,
because if we pitch it, say,
right. And
that's it, at least in the system. So we get
Absolutely.
primary care. It's really sitting there saying, you know, we can't manage these patients with this.
right.
It has to be to do that. I mean, that's been a problem here.
Right.
Thinking about that, particularly in trying to clarify. Is that the sorts of things that you have to crawl through to do that.
So later on in this presentation, I wanted to mention a interesting, I would say, initiative that was done by a VA ECHO group. That their telemedicine or telementorship program that was kind of trialed in the Puget Sound area, which I think they have done quite a bit over there in the state of Washington. So I thought that was a very interesting initiative that we should probably look at it, not just as a group at each institution, or could this be something that's done above institution? I don't know. That's my hope. So this is the part where people are comfortable reporting that they're comfortable managing insomnia. But the thing is, they're likely not really managing insomnia with the most effective therapy, right? So, so perspectives on primary care management of OSA, a qualitative studies of patient and healthcare providers. I believe this was done also. This was done in Calgary, Alberta. So basically, in the conclusion of this study, it says that although primary care delivery models may improve access to OSA management, or improving access probably just be, I order you a sleep study, I order you a CPAP, that's access, right? Before you can get to a sleep specialist. But stakeholders identify important challenges in the current system. Innovative models of care developed with inputs from patients and providers might mitigate barriers and support optimal primary care management of OSA. Basically, all they can really do at this stage is just to provide you with the therapy, but we all know that that's just not enough, you know. So what really is our role? Okay, so our job as a specialist, that I'd like to read the Code of Ethics from the American Medical Association 1847. A physician who is called upon to consult should observe the most honorable and scrupulous regard for the character and standing of the practitioners in attendance. The practice of the latter, if necessary, should be justified as far as it can be, consistently with the conscientious regard of truth, and no hint or insinuation should be thrown out, which could impair the confidence repose in him or affect his reputation. Man, that's a hard sentence to comprehend in my head, the way they describe it in 1847. But, you know, as a specialist, this is kind of what we wanted, what we're called upon to do, you know? So put it down here, the advancement of our modern day technology seems to have distanced ourselves from each other, you know, like we don't see each other, we don't walk by each other in the hallways anymore. We are practicing in the same system, but practically more than an hour away from each other, you know, by car. The value of interpersonal relationship, how can we balance efficiency, convenience, and the most basic need of human interactions, you know, PCPs and specialists. Oh, wow, I didn't know I found this nice cartoon here. So to our referring physicians, how do we better provide answers to their questions? How do we make our recommendations easy to follow? How much do we need to ensure adequate follow-up? How do we make our referring physicians feel adequately supported? And to our patients, obviously, how do we better take care of them? How do we make sure that they feel a real improvement in their quality of life, you know, with our help, along with their primary care doc? What about a team approach amongst the sleep specialist group, etc. Okay, so these are some of the thoughts that I had, and I will come more thoughts in our discussion later today. Our job as a specialist, this is the report part, what should be included, what should not, we spend a lot of time with our reporting and there's a lot of data in there, but is it something, or should we have different versions or reports gearing towards different group of referring providers? I don't know. I'll probably spring if we decide to go that route. Taken from a study done in the early 2000s, this is what primary care physicians regarded the importance of different factors in choosing a specialist. The big ones, the major ones here, medical skill, obviously, previous experience, appointment timeliness, quality of communication, likelihood that this patient will like this doctor that I'm sending him to. Specialist returns to primary physicians, blah, blah, blah. So those are the big things that they are looking for, and this previous experience with specialists and this appointment timeliness. So those are the big things that they are there. And then I don't have a good data as to how much better we're doing with this compared to that, say, 5-10 years ago. But that will be a good metrics to look at and to see if any kind of satisfaction from our referring base is actually increased. So communication breakdown in the outpatient referral process. This is very significant problem. This was studied in 2000, so 20 years ago already, but still timeliness of information from specialists, redundant aspect of the current process. Yeah, so, and then timeliness of information from PCP, like we take our fingers at each other, right? You're not returning to me. No, you're not giving me enough notes and information in your notes. So the fun part, future of this relationship. So first of all, they, again, this one was also done in the VA system, the Puget Sound area. The referral coordination team redesigned a specialty care to enhance special service deliveries and value of sleep medicine. So quality improvement project that was basically consists of 1 to 2 consulting nurses and 1 to 3 medical assistants. MAs perform all patient schedulings and also work to coordinate delivery or medical records from non-VA providers, to get other things back in. Those are what the MAs do or secretaries do. And 1 nurse coordinator and a part-time physician responsible for overseeing RNs and MAs productivity, maintain decision support tool, and coordinate team expansion. So to me, this sounds like they just have a very specific group of people that they're only really doing like the sleep study coordinations and stuff like that. And timeliness of care community has a very significant increase in terms of appointment days, less than 28 days, scheduled within 7 days, referral to community care is also getting better. Better time to have appointment schedule, better time to have appointments, better patient retention, satisfaction, time utilization, overall cost effectiveness. This is what they found. Relative satisfaction of patients with consults completed by traditional system or the referral coordinating team. So patient agreed that their contact was timely. Patient agreed that their care was timely. Patient agreed that they know the next step in their care. What do I do next? Who is gonna call me? Or am I gonna make an appointment to come back to see my sleep doc? You tell me to come back to see you in 2 to 3 weeks after my sleep study is done. But your next available is 3 months. What are we gonna do with that, right? Patient agreed that they were treated with respect. That's interesting how even the last question, I wouldn't think will make that big of a difference, but the new coordinated system compared to the traditional system, which potentially may be calling the central scheduling, calling the lab, just to figure out, when they need to go in for a sleep study, let's say, they feel you're treated with more respect. Projected values of additional provider time saved by the referral coordination team. So the referral coordination, obviously here, saved by a lot of times here. And I want to talk about this particular initiative that they're doing. And then let me just read out the abstract to you so you can understand what they're trying to do. Okay. So Sleep VA ECHO, which is the Veteran Affairs Extension of Community Health. And this ECHO idea, I believe, was first came out from University of New Mexico. is a national tele-mentorship program intended to provide knowledge about sleep disorders among non-specialty providers. The project goal was to describe the characteristics of sleep VA ECHO participants from primary care and their use of program obtained knowledge and practice. Sleep VA ECHO consists of 10 voluntary 75-minute long teleconference sessions combining didactics and case discussions. Out of the 86 participants, 21 self-identified as primary care team members and completed a program evaluation. Participants self-reported their applications of knowledge gained, including changes to practice as a result of program participation. The 21 participants represented 18 sites in 11 states and attended a median of 5 sessions, so half of it. They included physicians, nurse practitioners, registered nurse. Nearly all participants reported using acquired knowledge to care for their own patients at least once a month. 60% shared knowledge with colleagues at least once a month. 85% reported improved quality of sleep care for their patients, and 76% reported an expanded clinical skill set. The greatest self-reported change in practice occurred in patient education about sleep disorders, about 95%, and non-pharmacologic management of insomnia, 81%. That's a big difference, I think, because, you know, just by looking at this, I was gonna say, you know, that's quite different from the other paper that we're looking at, you know. So this could potentially really make a difference. And let's see, sorry, I just wanted to look at the chat to see if there's anything else here. Okay, maybe we can come back and look at them later. So, come here. Okay, so this is actually, I'm gonna stand up here. So I think this is very similar result to any kind of education that we receive in terms of the feedback, right? Every single time you go out, you give a grand rounds, you go out, you give a lecture, you give them everybody a piece of paper and say, how much better do you feel now? Everybody's like, of course I feel so much better. You know, otherwise, you know, what am I? Am I stupid? You know, like, you know, so I kind of take this with a grain of salt, right? But addressing patient expectations about sleep, doing better, I can understand that. Understand the spectrum of sleep disorders and impact on health. Yeah. Evaluation and management of chronic insomnia, 67% better. Evaluating patient with complaints of sleepiness with OSA, answering patient questions regarding OSA treatment, understanding impact of PTSD on sleep. All blue is increased comfort, and the green ones are kind of unchanged. And then there are ones that probably feel like, oh my God, I really don't know about OSA treatment. So they're becoming less comfortable, right? So provision of patient education, that's what they really find beneficial, right? So, or self-reported change in clinical practice, denominator noted after each domain, include those who answered, did not attend a session related to this content. So provision of patient education, non-pharmacologic management of insomnia, pharmacologic management of insomnia, evaluation management of RLS, diagnostic assessments of sleep apnea, evaluating efficacy of sleep apnea. So across the board, they all feel more comfortable. Again, this was done right after the telementorship session or these lectures are done. I think it'll be interesting to look at how comfortable they still feel a year down the road or 2 years down the road, right? Because their memory is still very fresh. So yeah, I can do this, but the more they do and the other things kind of sip in, I'm not sure, but it'll be interesting to look at. I'm sure hopefully they will review that as well with these people. All right, so this is primary care and sleep unit agreement and management decision for sleep apnea prospective study in Spain. I didn't include the protocols in there. I just thought that they're interesting dynamics of people, group of people that are trying to work together to provide a better care. And both of these protocols are actually done in Spain. So the ones that I saw, and I'm sure there are ones more out there. Coordinated program between primary care and sleep unit. Is that what they call sleep? Sleep unit out in Europe, right? Yeah, in Spain. Sleep unit for the management of obstructive sleep apnea. So those are the big things which we know we need help. Right, that's right. It's like this. Yeah, so so these are the protocols that they're trying to kind of come up with to do them, and many of these protocols are ongoing. I'll be very excited to see like what type of results they come up with, or if there is something that we could implement. And obviously insurance and all that other stuff, you know, kind of coming in, hospital administrations. But I don't know, at the end of the day, like what I mentioned previously, what's our job as a provider, you know, to our referring physicians, to answer their questions, to help them with the care for their patients. And obviously, ultimately, to have relationship with them and have them have better care and better outcome for our patients. So questions to consider: how much can we do? How do we do it more efficiently? The facts are out there, but what is the best way to raise awareness? You know, so really hope that referring docs plus the sleep docs does not equal to 2 docs. You know, hopefully it's not less than 2 docs, because they're saying opposite things. Oh, you need to treat OSA. You need to get you on your CPAP. My sleep doc says that you did it. You know, I haven't seen that. You know, I don't know if have you. So those are the things that I want to consider. I want you to consider, and then I want to leave the last 10 minutes of this presentation for questions or discussions. Lastly, this was my 3 kids long time ago. Not that long, actually, probably 2.5 years ago. And what I'll say is that, you know, they do grow. So, you know, hopefully our care for our patients also can grow in a positive direction. All right. Thank you very much.